Hello guys, can you see me? Can you hear me? A very good evening. This is Dr. Ranjith. Hello Dilip. How are you? So we'll be discussing few more questions and from you all, right? This is dedicated for MLE. So we will be hopefully in Unacademy we'll be starting MLE classes as well, hopefully soon, right? It's in the track. Hope that helps you for you guys. So here we'll be discussing I'll have intermittent YouTube session as well as in the special classes we'll be discussing few questions from your world, whichever might help for you. Fine. Okay. So I'm going to share all the word questions only, right? You are going to read the questions and most probably give your answer whatever you think. Then we'll see how you will goes is they'll be explaining every option why it is wrong, right? We shall try to go in the same way as well. Fine. Okay. So before that, that's some good news for you. I hope it's a good news for you. There's a NEET PG compact. There's a question coming up on PG scholarship exam coming up, and we have prices till 200 rank. That's one thing amazing because most of the time we used to have only top 3 people having prices. So if it helps for you or if any of your friends, you can share it with them. So 10th October 11 a.m. So you can enroll using any course. If you don't have a code, you can use Pathology. It's a free test which might be useful for you guys. Fine. And the raise hands things, and there are limited time offers if you want to enroll to something. This is the navigation flow for the test usage in the app and in the website. Fine. And we have a QBank, and hopefully we hope to see most of you guys in the maybe the honors slide soon. Fine. Okay, so we shall go to the first question. I'll zoom it a little bit. I hope it is clear. Okay. A 32-year-old chef accidentally slices the tip of a thumb and hurried trimming rib pie steaks, right? Whatever it is, fine. With a knife, the laceration extends through skin to a subcutaneous pulp, fine. Which of the following sequences is most likely to occur in the subsequent wound healing process? See, there are 6 options here. The only thing in MLE is an exhaustive exam, that's all, right? So read the options carefully, and whatever comes to your mind, tell that an answer. They're asking just the sequence of wound healing. The question might look very big, but it's a very, very simple one, right? Just go through all the options and see what will be the correct answer. Fine. Okay. Great. I'll read along with you. Angiogenesis is definitely not the first step. So option A is wrong. B is also wrong. Cellular infiltration looks like good, and you have an angiogenesis, but fibrin clot, right? So immediately, perfect. Immediately, right. Prithviraj, great. D, I will go unlikely because what is the first step after any wound? Here there's a laceration wound, right? You have a laceration here. So am I right in saying that after laceration we'll have bleeding? Undoubtedly bleeding will be there, right? Yes. So after bleeding there will be a clot formation. So do you think a cellular infiltrate happens before the clot or after the clot? A cellular infiltrate happens after the clot formation, right? So clot formation is the first step. So how a clot is going to help us, we'll go with whatever Robbins gave us in first and second primary intention. We'll look at that soon. Fine. So here my fibrin clot formation is the first. So answer could be either E or F because only those two has fibrin clot formation in the first answer, right? In option E, it's followed by angiogenesis, then cellular infiltration. That's not the point, right? So fibrin clot is the first one, cellular infiltration is second one, angiogenesis is the third one. The correct sequence of the 3 options given here will be option F, right? Prithviraj was correct first. I don't know why did you change it to option D, right? So be confident on yourself. If you are correct, you are going to be correct for sure. Fine. So generally we miss this step. We don't include clot formation as a process of wound healing, right? That should be missed, right? We should always include clot formation as a process of wound healing. For the simple reason why clot becomes extremely important is, let's assume there is a laceration or let's take it as a cut, a clean cut, right? So here I'm having an empty space. Cut is nothing but an empty space, right? There's discontinuity of the tissue. I have an empty space. So in this empty space, ideally what should happen is the bridging, the fibrosis, wound healing, everything should happen. For that, I'm right in saying that I need neutrophils, I need macrophages and many cells to come inside, right? So the cells should come into this place. So do you think cells can come into an empty space? It cannot. So I need some background, some base for my neutrophils, for my macrophages, for your fibroblasts, everything to act. That base is my clot formation. Okay. So when I have a clot formation, clot, or I can use the word scab, whatever it is. So clot formation acts as a base for everything to proceed. So in the clot, yes, obviously neutrophils will come inside. That's my cellular infiltrate. Will remove all the necrotic debris. Will fight against any bacteria present. Then it will be followed by macrophages. Macrophage will remove the neutrophils. That's the second sequence. After macrophage infiltration, what do you think is the next step? What do you think will be the next step after macrophage infiltration? Macrophages come inside. What do you think will happen next? Macrophage will eat everything. Then macrophage converts them into my activated macrophage. If I need to put in an MCQ here, so what type of activation happens here? M1 or M2? We have two types of activation in macrophage. Before scar, we do have few steps, right? So we have two types of macrophage activation, M1 and M2. Here it's going to be predominantly M2 activated macrophage and not an M1 activated macrophage. M1 happens in your chronic inflammation granuloma formation. M2 happens here, right? Perfect. So once M2 happens, this M2 will secrete my VEGF, PDGF, platelet growth factor, and your transforming growth factor beta. So all these are going to help me in the formation of neoangiogenesis. That's when I have the granulation tissue, and then my TGF beta takes the upper hand and makes the granulation tissue a fibrotic scar tissue, right? Perfect. So then comes my angiogenesis, and then comes your scar formation. Okay, this is the ideal thing. This is the ideal timeline. So I'll have a fibrin clot as the first one, cell line infiltration is the second one, and neoangiogenesis as the third one. Maybe after that, if I have to follow, I'm going to add then fibrin, your scar formation, or your collagen scar formation, or whatever scar formation is, fine. After scar formation, I'll have remodeling of the scar, then my scar becomes more strong, fine. That's a sequence of wound healing, okay. Go to the next question. Fine, read the question carefully and give the answer whatever you think it is. I'll give maybe a minute or so. After that, I'll also read the question along with you and let's solve it together, fine. Be very slow. You have entire minute for us to use this. I hope it's clear. Options? Any takers? Okay, what is the diagnosis here? The diagnosis is straightforward given the question, right? I'll read through the question. A 62-year-old evaluated for worsening cough, shortness of breath, episodic hemoptysis for the past 6 months, and he has lost a 15 kg weight over the same period. 6 months, 15 kg weight loss is definitely a significant weight loss. I'm worried about that, fine. And a 50-year smoking history, pachyia history, no alcohol, nothing. So with the history and the weight loss, can I kind of say that this person must have been suffering from a terminal stage lung carcinoma? Hopefully. And the person also has mediastinal lymphadenopathy, a large lung mass in CT scan, and pleural effusion as well, right? So most probably my diagnosis here is a terminal stage of lung cancer. The reason I'm saying terminal stage lung cancer is this finding. The patient appears cachectic. Cancer cachexia is definitely seen in terminal stage of an illness, right? So I'm having a patient with a lung cancer, right? So lung cancer with terminal illness in the terminal stage. So in the terminal stage, what is happening here is patient is having cachexia, cancer related cachexia, right? That's the thing here. So it's cancer related cachexia. We all know that. I cannot say exactly what it is, adenocarcinoma or anything, because I don't have any other information. It can be any carcinoma. If I'm going to go with the incidence wise, I'm going to go with adenocarcinoma predominantly, fine. Since there's a smoking history, I would keep adenocarcinoma down the road, but still, fine. So this is cancer cachexia, right? So any terminal stage cancer, not only for lung carcinoma, any terminal stage cancer will have cachexia. We already know that why cancer cachexia happens, right? So what do you think is the reason for cancer cachexia? The etiology of cancer cachexia, we know that we are not exactly pinpointing the etiology. What we have assumed and what we have seen in patients in the terminal stage of cancer is there's increase in amount of interleukins, 1, 6 and TNF. This is what we have seen, right? So how this 1, 6 and TNF is going to eat away the patient's masses, these are going to stimulate my ubiquitin proteasome pathway. Ubiquitin proteasome pathway will destroy your proteins, right? The primary proteins these are going to destroy is your skeletal muscle protein, both my actin as well as myosin. That will be destroyed, fine. So this will stimulate, that's how they're going to act. They stimulate my ubiquitin proteasome pathway. Once they stimulate the ubiquitin proteasome pathway, they're going to destroy, primarily going to destroy muscle proteins. So that's why most of the cancer cachexia patients will not have a good amount of muscle mass. Everything will be destroyed, right? So when they destroy muscle protein, that will result in cachexia. So if you know this, now we can easily look back to the options and we'll definitely able to write the correct answer. Fine. First thing, a covalent attachment of ubiquitin to muscle proteins. Perfect. Proteasome acts via that only. Proteasome cannot destroy any muscle. Proteasome can destroy only when a protein is tagged with ubiquitin. If ubiquitin binds to a protein, I'm going to say that, okay, this is a protein which should be destroyed. Proteasome comes and destroys that, right? They are specially targeted muscle destruction or protein destruction, right? So that will be the right answer. Plasma membrane rupture with leakage of cellular contents. We'll look at the other options also. Tell me what process in pathology explains this. Plasma membrane rupture with leakage of cell contents. What could be the possible findings in here? Can I say it is necrosis, right? Something related to necrosis, or maybe any muscle damage. It can be anything. So most likely I'll think of a necrosis, right? That's the first thing. Perfect, fine. We'll go to option C. Great. So option C says plasma membrane instability due to defective dystrophin. Perfect. The third option. Tell me what is the diagnosis here? What's the diagnosis here? Dystrophin is defective. So it's classical. I have only two options. Either I have DMD or a Becker's muscular dystrophy, right? DMD or your Duchenne's or Becker's muscular dystrophy, most of them will have this. I'm not able to say what it is because I don't have the entire clinical picture to differentiate that, right? Next one, progressive shortening of chromosomal telomeres. Tell me what comes to your mind when you look at this? Okay, perfect. Can I say that progressive shortening of chromosomal telomeres could be even a normal finding in aging process? Yes, that's cell division, right? Anything aging, cell division, definitely perfect. It's nothing but cell division or maybe an aging process, whatever it is. Unless I have a history related to something which is going to point out to some diagnosis, otherwise it's just a normal aging process, that's all. Next, fifth option, reprogramming of undifferentiated mesenchymal cells. Okay. Undifferentiated mesenchymal cells, reprogramming, or maybe I'll rephrase it so that it's easier for you. It's metaplasia, that's all, perfect. It's a reprogramming of stem cell. Undifferentiated mesenchymal cell, I'm going to call it stem cell. This is what I'm going to see in your metaplasia, perfect. See, the good thing about UWorld, if you're especially concentrating on USMLE, UWorld more than the questions, the options lead to another diagnosis. That's going to help you in solving many other questions, right? So that's the reason the explanation of UWorld is very important. Everything will be explained in UWorld so that if at all some other question comes in the later topic, you'll be able to crack it. Fine, great. So I'll go to the next one. Okay, I hope it's clear. I'll read the question again. Maybe for 1 minute, take 1 minute time and then tell the answer. Then I'll discuss about the question. Something highlighted there might be the right answer or might not be the right answer. Don't get disturbed. Okay, let's start. I'll read the question, then we'll go ahead. A 34-year-old comes to the office with a vague abdomen pain for several months. She has no significant history. The patient doesn't use tobacco or alcohol. Temperature is normal. Physical examination, right upper quadrant fullness. Abdominal imaging reveals a dense mass. Angiography means a well-demarcated, highly vascularized tumor surrounded by normal liver parenchyma. Most probable diagnosis, since it's an young age and since it's well demarcated, highly vascularized, I'm leaning towards your hemangioma. I'm not sure about it though. Fine. Which of the following substances is most likely to contribute to the blood vessel development in the patient of the tumor? So I'm right in saying that I'm talking about neoangiogenesis, right? So here The question is not talking about the liver tumor, they are talking about neoangiogenesis, that's all. So I'm right in saying that any tumor in my body should have neoangiogenesis, yes or no? Any tumor in my body should have neoangiogenesis, right? So when you go to neoangiogenesis, even we might have read this in wound healing process, well, the predominant one which helps me in neoangiogenesis, vascular endothelial growth factor, we all know. I don't have that in the option for sure, right? I don't have VEGF in the option. So first thing what comes to me in my mind is VEGF. That's not there, right? We have read that after VEGF, what comes into our mind is a beta subunit of fibroblast growth factor, right? Perfect. Second thing for me is my beta subunit of fibroblast growth factor. These two are the predominant neoangiogenic factors, right? Pro-angiogenic factors, right? So I have fibroblast growth factor. This will be the answer. I'll come and say why not an epidermal growth factor for sure. Fine. Option B is the answer. That's highlighted is not the correct answer, right? It's an offline URL. I'm just taking screenshots of it. Fine. That's all. Epidermal growth factor might not cause neovascularization. Epidermal growth factor might help in your tumor progression. It help in the uncontrolled cell division, but not for my neoangiogenesis, not for my neovascularization. So how epidermal growth factor might relate to neovascularization is, this will increase the cell mass. So once cell mass increases, obviously what's going to happen is there's going to be relative hypoxia. Whenever there's hypoxia, this guy comes up and this guy comes up, and that will cause neovascularization, right? Epidermal growth factor is not directly linked with neovascularization at all. Do you remember it? It's a thing which might be like an initiating factor for the cancer, right? That's what happens in your thing, okay? Your interleukin 1, again, and just to give some information about it, interleukin 1 actually, your interferon as well as interleukin, both option D and E, actually what they can do is they can trigger the release of VEGF. So it's not directly involved in neogenesis. They will trigger VEGF, then yes, it might cause it. And insulin-like growth factor is going to help in the metabolism of the cancer cells, which we'll see in some other time, fine? So the answer here is fibroblast growth factor, not your epidermal growth factor beta, fine? Okay, great. So now we'll go to the next question. Same thing, read the question carefully. It is a big one, so I had given the options separately, okay? I hope it's clear. Okay, any guesses? Okay, EBV, good, Satta. Fine. I hope the font was okay. I'll exclude the options. I'll just go to the question alone. Fine. A 13-year-old boy admitted to the hospital due to fever, fatigue, and the past week. The patient recently received a cadaveric renal transplant for glomerulonephritis, and his immunosuppressive medication regimen was started for a month ago and to avoid rejection. Perfect. The temperature is okay, decent. Heart and lung examination are unremarkable. Liver is mildly involved. Spleen tip is palpable. But there is a notable adenopathy in the bilateral inguinal and axial lymph nodes. A complete blood count shows mild leukopenia, and this is from the biopsy. Okay, you guys said it's EBV. Fine. I'll come to EBV. The thing I can easily write by exclusion. Do you think Aspergillus, Bartonella, Parvo, Cryptococcus, will they have any involvement of lymphadenopathy? Unlikely, right? So by ruling out, I can easily say it's an Epstein-Barr virus, right? So this thing is not primarily only related to Epstein-Barr virus. We have to come to the microscopic diagnosis as well. Let's assume, let's see that if we can pick up the diagnosis here or not. So this is a lymph node. Okay, only a little bit of lymph node is there. Just I want to tell you, do you have cortex medulla in this picture? Or in other words, is the normal architecture maintained? Do you have normal architecture being maintained here? The answer is no, right? I don't have a normal architecture maintained, right? So let's say this is my endothelial cell, okay? This is the neoplastic cell, let's assume. So am I right in saying that the neoplastic cell is bigger than my endothelial cell? Yes. So in that case, can I say that this is definitely a large lymphoid neoplasm? Small, medium or large? That's how we consider, right? This is a large lymphoid neoplasm. It's a neoplasm where I have an effaced architecture. There's no cortex, no medulla, nothing is there. It's a large lymphoid neoplasm. If I'm going to say B cell related, what could be a diagnosis? That's very common in EBV, and that's also common in an immunosuppressed individual. Only one B large lymphoid neoplasm is there. What is a neoplasm? It is DLBCL, right? So this biopsy diagnosis DLBCL. Okay. What triggers the DLBCL? Burkitt's is intermediate, right? The biopsy diagnosis DLBCL here. DLBCL is the only large lymphoid neoplasm. Perfect, right? It's just DLBCL. So here it's a 13-year-old kid. Now you should have automatically a question. DLBCL is not a finding to be seen in 13-year-old. It is definitely a finding seen in an elderly person, right? 50 or 60. But what triggers DLBCL in this kid is the immunocompromised state. Has been given a transplant, an immunocompromised state can relate an EBV infection, will make it DLBCL, right? This diagnosis is DLBCL, which is immunocompromised individual. So in general, I'm just going to extrapolate this a little bit more. In general, DLBCL, do they have a good prognosis or bad prognosis? In general, leave this. Good or bad prognosis? General DLBCL doesn't have a good prognosis, right? If a DLBCL happens due to immunocompromised state, DLBCL has a better prognosis compared to a de novo DLBCL, because here the primary modality of treatment for me is to remove the immunosuppression. If possible, I remove the immunosuppression, automatically my body can fight against it, and immunosuppression related DLBCL generally has a good prognosis, fine? Just an extra point here. Now let's come to the other options. Aspergillus. How do you identify aspergillus in a biopsy? Tariq, Richter's transformation is, you're leading to one more question. It's CLL transforming to DLBCL, right? Not every other DLBCL. So your aspergillus, first I won't see them in a lymph node. The finding I'll see in aspergillus is in septate fungi, right? It's septate at 45-degree branch. That's how an aspergillus look. Okay. Okay, let's assume I'm having in a lymph node or in lung, mostly aspergillus is common. Let's assume I'm having a lung aspergillus. Aspergillus is difficult to identify, right? So what stain do I do to pick these guys up? I do have a special stain. I have two special stains ideally. One special stain helps me to pick it up. What is that? I have GMS, which is a better stain, and I have PAS. These both are stains for fungus. So if you have any question which says that GMS positivity, KOH is not used here. I'll tell you KB doc and group. KOH mount is used for dermatophytes, right? Your skin infections, skin fungal infections. I cannot use a KOH mount for a biopsy, not for all the fungus. I'm going to use either PAS or GMS. GMS is much better. Gomori methanamine silver, that's much better than PAS, fine? If the same thing comes as in skin infection, yeah, KOH mode, scrapings is definitely helpful, fine? Bartonella Hensley, what do they cause? What do they cause? You should know this. Bartonella Hensley. Your microbiology. They do cause lymphadenopathy, right? They cause cat scratch disease, and yeah, one of the thing in cat scratch disease, they do cause lymphadenopathy as well. So in lymphadenopathy, Bartonella can involve have a lymphadenopathy. In microscopy of a Bartonella Hensley or a cat scratch disease, we have a very, very peculiar finding. What finding is that? What finding do you have? We have stellate granulomas, right? Perfect. Granuloma is correct. I would wanted the stellate word here. The stellate granuloma is diagnostic of an Bartonella Hensley. Fine. Okay. Perfect. So one thing about Satak, you're correct. One thing about stellate granuloma, one unique thing is, anywhere when I say granuloma, what inflammatory cells do I expect there? Macrophages or neutrophils. Every granuloma, tuberculosis, crypto, whatever it is, histoplasmosis related or your Hodgkin's, whatever it is, I expect macrophages, right? In stellate granuloma, yes, I do have macrophages. One important difference is here I have micro abscesses. Abscess in the sense I'll have neutrophils here as well. Stellate granuloma is one granuloma, you'll have lots of neutrophils in the microscopy, fine. That's the unique thing about ciliary granuloma, and obviously the size. It will not be exactly star shaped, it will be irregular here, fine. Okay. EBV we know. We look at parvovirus and cryptococcus. See, parvovirus causes what disease? Related to hematology. Don't say that slap cheek appearance, this definitely will be there. In hematology, parvovirus is involved in one of the particular thing, which I'm going to say, an aplastic crisis, right? Or a pure red cell aplasia. Parvovirus is involved in pure red cell aplasia, PRCA, or an aplastic crisis in your hemolytic anemias, fine. So when a parvovirus is involved, will it destroy RBC, WBC platelets or only RBC? In aplastic crisis also, it will destroy only RBC. That's a unique thing about parvovirus, because parvovirus enters your erythroblast, the precursor, via a protein called as an P surface protein. Okay. The erythroid precursor is P surface protein. Via that they enter and they will destroy the erythroblast. Not they're going to destroy the RBC, they're going to destroy the precursors. That's why aplasia, there's no formation at all. Plasia for formation, A is absence of formation. I'm not going to have a thing, right? P antigen. Just an MCQ, if possible, if you can relate. Antibodies to P antigen. What type of disease will it cause? If you don't know, I'll tell for sure. Right? So parvovirus here, it's going to cause via P antigen, it enters inside and it's going to destroy it. One microscopic finding, when I have a parvovirus infection, we have something called as a dog ear erythroblast. The pro-erythroblast will be generally affected, so you'll have a dog ear appearance. You have a big erythroblast. It's in virus. Any virus will have an inclusion body, obviously, right? You have a completely big virus and have an inclusion body in the virus, and the cytoplasm, for peculiar reason, it has some cytoplasmic bleb, right? That looks like a dog ear. So in a biopsy, bone marrow biopsy, you see a dog ear appearance in an MCQ. Think of an parvovirus B19. Okay. Antibodies to P antigen. Antibodies to Rh antigen resulted in one warm autoimmune hemolytic anemia. Antibodies to I antigen resulted in your cold autoimmune hemolytic anemia. We have third condition called as paroxysmal cold hemoglobinuria. There we have antibodies against P antigen, right? Perfect. Okay. Cryptococcus, again, I need the immunocompromised state. I need your meningitis and extranodal involvement is more common in cryptococcus, right? I want you to remember two stains in cryptococcus. The first stain, what you want to remember in cryptococcus is, which will be more demonstrable on a microbiology CSO specimen. What stain will help you identify cryptococcus? The stain which will highlight the capsule. I'll write this here. So cryptococcus, there are two things here. The first one, which all of you must have known, is India ink, right? So India ink is a stain. I can do it on a CSS preparation. It's a liquid based stain. I cannot do an India ink on a biopsy, right? It's difficult to do an India ink on a biopsy. When I'm going to do a biopsy for a cryptococcus, you have a pathology related question for cryptococcus, then I'm going to use mucicarmine. So mucicarmine and India ink, both of them, what they're going to do is they're going to highlight the cryptococcus. That's going to help me in the diagnosis. Perfect, fine, right? So those are the something related to the other options as well. Okay, go to the next question. Great, read the question carefully. It's an easy one, and then come to the answer. Maybe I'll give you 40 seconds. Okay, diagnosis. First diagnosis. The patient, 28-year-old, having a breast lump. Mother died due to ovarian cancer at 34. Again, I'm going to be worried. And died due to breast cancer at 32. So I'm having a very, very early onset breast and ovarian cancer. So I'm going to think of a familial breast cancer. When I come to familial breast cancer, it's going to be BRCA related, right? I won't go to P53, Prithvi, I'll tell why. When I have a familial lesion, I'm going to think of BRCA first, fine? P53 I'm going to think of later. The reason is BRCA1 and BRCA2 constitutes more than 70 to 80% of the familial breast cancers, just because of the incidence, that's all, right? Okay, just because of the incidence, I'm going to think of a BRCA when it's familial. When it's sporadic, yes, my P53 will be the first choice I'm going to think, right? So BRCA1 or BRCA2, whatever it is, okay? BRCA1 is definitely more common than BRCA2, obviously. BRCA is a complex which is going to help in the DNA repair mechanism. Actually, BRCA helps in chromosomal breaks. It helps to heal the chromosomal breaks. Like you must have read about many DNA repair diseases, right? I'll tell you the DNA repair diseases. You will tell me what abnormal cancer syndromes you'll see them. Methyl mismatch repair defect. What cancer syndrome will we see? Yeah. Methyl mismatch repair. It's seen in here. Lynch syndrome or HNPCC, right? BRCA is one we can see in all the breast cancers. Okay, let's say that nucleotide excision repair. Where do we see nucleotide excision repair? Nucleotide excision repair, you're going to see it in xeroderma pigmentosa. A defect in nucleotide excision repair will be seen in xeroderma pigmentosa, and I say xeroderma pigmentosa, that's going to cause multiple skin cancers and everything. Yes, Sunny, you are correct. Fine. Since the history is here familiar, I'm going to go with BRCA1. Okay, perfect. Okay. So these are few things which can keep repeated because these are important DNA mismatch repair syndromes. Familial, you should know when do you suspect HNPC. I think we have an MCQ down the road. We'll see about it as well. Okay. Okay. Read the question carefully. This requires a little bit of more time. Come to a diagnosis first, then go to the answer. Bloom as well. There are lots of them like ataxia telangiectasia, Bloom syndrome. Many are there. I'm just limiting it for the purpose of discussion. Answer, Dilip. Okay, everyone is for multiple myeloma. We have 3 people for multiple myeloma. Okay, 1 for something else. Great group. Fine. We'll read the question and we'll see where it fits into. Fine. A 68-year-old man comes to the office due to persistent back pain for past several months. He is a retired veteran, not seen doctor for many years. Fine. He has smoked a pack of cigarettes daily for 36 years. BP is fine, pulse is fine, cardiopulmonary examination is unremarkable, abdomen is soft and tender, fine. There is focal tenderness over the 10th rib, L1 and L2 vertebral region. Neurological examination normal. A radionuclide scan, will come to it, Rajat. A radionuclide scan imaging reveals increased activity in multiple vertebra corresponding to the painful areas. Perfect. So can I at least confirm here there is some malignancy involved? Yes. Prithvi and Rajat, change the answer. It's fine. I want you to say why you change the answer. I am sure you must have read the question carefully, then you must have changed the answer. Next time, I want you to do it first itself, right? Read the question carefully, the first go. Here I am having definitely some cancerous involvement. Next line gives me a clue. Routine radiograph shows sclerotic lesions, right? Sclerotic lesions. Do you think multiple myeloma has that? Or multiple myeloma will have lytic lesions? Multiple myeloma will have lytic lesions, right? It's not going to have sclerotic lesions. It's punched out lytic lesions. So I'm going against multiple myeloma, not a multiple myeloma, right? So again, even in multiple myeloma, let's assume it is lytic lesions only. Can I diagnose multiple myeloma with lytic bone lesions alone? You need bone marrow biopsy, the plasma cell percentage, CRAP criteria, or any of the biomarkers of malignancy, right? I don't want. Perfect, Prithviraj, right? So look at the other options, fine. These are the only information I have. I have multiple lesions, multiple mets in the bone. That's the only thing here. And I have sclerotic lesions in the X-ray. The first option, hematuria and polycythemia. What does it lead to? The option A, I have hematuria and polycythemia. Hematuria could be the symptom of a renal cell carcinoma. Polycythemia could be the paraneoplastic syndrome. Possible? Yes. So I'm just going to ask you, can a renal cell carcinoma go into the vertebra? Possible or not? Can they go into vertebra? They can go into vertebra, right? Perfect. So now I need to rule it out. renal cell carcinoma, when it goes to vertebra, I'll have osteolytic metastasis or osteosclerotic metastasis. Here also you'll have osteolytic bony metastasis. Fine. So I can rule them out that as well, right? So again, one thing which helps me is the radiographic sclerotic lesions. Lung mass elevated parathyroid related peptide, right? So someone, Dhruv, I think you said this, right? Lung mass elevated parathyroid related peptide. Am I right in saying that PTH related peptide will cause an hypercalcemia? Here also I'm going to have more of it's going to remove everything, and moreover, lung unlikely to go for bone. It will go for bone. I'm not saying I'm going to put it down the road, right? Lung carcinoma unlikely to have it, and lung carcinoma, if it's PTH related peptide, it's a paraneoplastic syndrome. It's not due to the bony metastasis, right? So I'm going to rule that out as well. Fine. Next, lymphadenopathy and BCL2 overexpression. BCL2 overexpression will be seen in which tumor? But that also can involve the bone and bone marrow. So only I'm coming to it. BCL2 overexpression, which tumor? Follicular lymphoma, right? Follicular lymphoma will also cause lytic lesions only. It can involve the bone marrow, it will cause lytic lesions only. I'll come to it, Sunny. That's what I said, that when I'm having an cardiopulmonary examination unremarkable, and when I'm taking a bone scan, right, which if I'm picking up lesions in the vertebra, if it is a lung cancer, that also would have been picked up in the scan. I'm not seeing that. When I'm not seeing that, smoking history alone is not going to relate to it, right? I'm presenting with a back pain in lung cancer. Again, it is PTH-RP is in paraneoplastic syndrome. It's due to lysis of everything. Hypercalcemia will be the finding. Again, I won't have a sclerotic lesion there. So I'm going to rule out that as well, fine? So last option here is nodular and elevate of PSA. Prostate can cause bony metastasis. Prostate can present as bony metastasis, and prostate will have sclerotic lesion, right? So this is the correct answer, fine? You will have one finding, one clinching point. It's a very good question where it covers everything. Again, what helps me in the diagnosis is the basic. The only thing I need to know is these sclerotic mets. Where do I see? First thing, already we know prostate, right? Prostate is one place where osteosclerotic mets is very common. Second, small cell carcinoma of lung, again common. Okay. Small cell lung cancer predominantly goes to the brain. Presenting as an osteoblastic or an osteosclerotic metastasis for a small cell lung cancer is unlikely, right? That's the reason I'm keeping it down the road. Prostatic cancer presenting as an osteoblastic metastasis is common, so commonality I'm going to go for that, fine. Third, osteosclerotic lesions can happen in Hodgkin's lymphoma. Okay. A mixed osteolytic and osteosclerotic lesions. This is possible in GI and breast. Breast is one which can have both osteolytic and osteosclerotic lesion. Lytic lesions, I'm not just limiting myself to metastasis. Multiple myeloma, first possibility I'm going to think. If not, I'm going to think an non-small cell lung cancer. Okay. Fine. That's a second possibility. RCC, NHL, lastly melanoma, right? This table becomes extremely important for us to understand the question. Okay. Yeah. This was a good question. I am not sure how many of them got it correct in the real U world as well. If you are solving an online U world, you will be able to judge what portion you have, because it's a little bit of on the difficult side. But yeah, when you read the entire question, few of you changed the answer. So the thing here is follicular carcinoma also will have mostly an lytic lesion. They are pulsatile metastasis, right? That is, follicular carcinoma of thyroid will cause pulsatile metastasis. They'll also come in the lytic lesions. Okay. Fine. Next one. Okay, read the question carefully, then come to the answer. I'll give you 1 minute and then I'll go to the discussion. It's a simple one. Okay, let's discuss it. Fine. A 48-year-old woman comes to the office with a sore throat for the past 3 months. On examination, she is found to have an enlarged ulcerated left tonsil. A mass is there. The patient undergoes a biopsy and shows a squamous cell carcinoma. See, it's a very, very simple one. I'll tell you now, you'll be able to tell the answer within a minute. Squamous cell carcinoma in the oral cavity, right? I'm having oral or let's say oropharyngeal squamous cell carcinoma. Which virus is involved in oropharyngeal squamous cell carcinoma? Right. Now look at the question. Actually, you have a clue as well, right? Further evaluation shows viral genome protein, right? So it's an oropharyngeal squamous cell carcinoma, which is most likely HPV related, and HPV has 2 proteins. What are the proteins? I'm sure you will be by heart by this time for this. E6 and E7 proteins. E6 reduces which? E7 reduces 1. E6 reduces my P53 and E7 reduces my retinoblastoma. I don't have P53 here, so I'm going to go with retinoblastoma only. Both the options will not be there in the question because HPV acts synergistically by inactivating 2 of the tumor suppressor genes. Fine, perfect. Okay, it's an indirect one. They didn't give you the clue HPV, but yes, they have given the clue of viral genome. Even if viral genome is not given, oropharyngeal cancers, laryngeal cancers, cervical cancers, pineal cancers, anal cancers, you have to think of HPV association. That's like one common thing is common for all these things. Okay, great, fine. Next. Okay, the next one might be again a little bit of googly. Just read the question carefully and answer. Don't jump to the answer. What comes to your mind first? Read carefully and answer. Sunny, it is good, right? If your question has lots of information given for you, the question should be a little bit easy, right? The problem with this year NEET PG exam was for a consultant level, it is, I would say, easy to moderate paper. Most of the students felt it as a moderate to difficult one. The simple reason, experience is lacking, that's all. Why most of the faculty said that there's a very good paper is, that's how we evaluate a patient, right? When we evaluate a patient, it looks easy for me, but evaluation is what you guys want to learn. Hopefully, if NEET comes in this way, it's good for all of us. Okay, we'll come to this question. We have a classical diagnosis here. It's an infiltrating ductal carcinoma. There's no problem in the diagnosis. That's already given here. It's an infiltrating ductal carcinoma, right? A right mastectomy and your axillary lymph node dissection is scheduled. Overexpression of which of the following markers is associated with an aggressive disease in this patient? That's a question. Okay. 2 of you have answered option D. I'm going to go for those 2 first. HER2/neu and ER is also has come into place, right? I'm happy that you didn't answer this because BCL2 is unlikely related to your IDC of breast, right? So we'll rule that out easier. So ER and PR will be overexpressed or will be lost. ER and PR will be overexpressed only, right? So I just want you to say that if a tumor is ER positive, PR positive, good for me or bad for me? These 2, yes, it will be overexpressed, but they're actually good prognostic factors, right? My question is, which of the following will be associated with an aggressive disease, right? It's not the aggressive disease. When ER and PR is positive, I can give an hormonal therapy. I'll have a better response for the patient, right? Perfect. Next, I have C and D, right? HER2/neu will be overexpressed or it will be lost. HER2/neu also will be overexpressed, right? This also is going to be overexpressed. Answer is HER2/neu only. I'll tell why not mutated P53. Fine. HER2/neu overexpression is associated with a bad prognosis only. It will make the disease more aggressive. I'll tell how. You must have read about luminal A, luminal B and luminal C, right? Those variation of cancer. Luminal A and B is ER/PR positive. When I have HER2/neu expressed alone, HER2/neu alone positive, that will have a little bit worse prognosis than an ER/PR positive tumor, right? So this HER2/neu alone positive will have an aggressive disease. The only thing, one good thing for me here is HER2 positive, I can give trastuzumab. When I give trastuzumab, the patient will respond better, that's all. But HER2 is associated with an aggressive disease only, right? That's the answer. Why not P53? Because when I compare HER2 and P53, P53 is the worst of all. My question is clearly saying overexpression. Tell me, P53 will be overexpressed or P53 will be lost? Dhruv, you are correct. P53 is a tumor suppressor gene. So P53 should be lost, right? Loss of tumor suppressor gene will cause the cancer and not overexpression. So loss of P53 will cause the cancer. This will be lost, not overexpressed. So that will not be the answer. Fine. That's the only important thing which here. So it's not P53. Diagnosis HER2. Answer is your HER2. Fine. Great. Okay. Perfect. We'll go to the next one, and maybe this again is a bit of a tricky question. The next question. Read the question carefully and go with it. Okay, Ranjith has started the account and has gone with E. Fine, so here also there is diagnosis already given, so no problem for me. Diagnosis is something there. My question is here is, I'm using a monoclonal antibody for EGFR, right? This is where my question starts. I'm using a monoclonal antibody for EGFR where I'm going to use it to destroy it. The question says that there is one more activating mutation in which can happen in this person, which might make the therapy ineffective, right? APC beta catenin. APC is a proto-oncogene or tumor suppressor gene? It is a tumor suppressor gene, right? So will it be activated? It will not be activated. So I'm going to strike it off. I'm not even coming into the question, but I can strike off few things easily, right? Second, P53 also I'll strike it off. Because again, the question says an activating mutation, it's loss of function mutation. So those two are gone totally, right? So EGFR is an epidermal growth factor receptor, right? That's your EGFR. So you have, KRAS is bad prognosis, perfect. If you can answer the question in that way also, I'll exactly say why KRAS is bad here, fine. We already know KRAS is bad, right? So why KRAS is bad here is, these two are not important. It's not going to alter the prognosis, especially at least for this treatment. Why KRAS is bad for the treatment? The question exactly says that an activating mutation of the following will make the therapy ineffective. So what happens is, EGFR is a growth factor receptor. So let's assume this is my growth factor receptor. This is my cell where I am having growth factor receptor. So am I right in saying that every receptor will have a downstream pathway? Yes, will have a downstream signaling pathway. EGFR's downstream signaling pathway is RAS. Okay, EGFR's downstream signaling pathway is RAS. So they're in the same hierarchy. So what I'm going to do as therapies, I'm going to use antibodies which can block this. Okay, I'm very happy I'm blocking EGFR. If there is a mutation in RAS, the same pathway, will this drug work? It will not work. I'm just talking, knocking off the head part. Still this person is going to function. So when I have a KRAS mutation, that's why we say that KRAS mutation carries a poor prognosis. It will knock off the EGFR effect, because this will definitely result in proliferation. Proliferation without the presence of this, fine? In the absence of my growth factor, in the absence of my growth factor receptor, KRAS mutation can initiate the proliferation. That's why KRAS mutation has a bad prognosis, right? That's an answer here, fine? Clear? Any doubts here? Hopefully it was clear. Okay, we go to one more question and we'll call it off already. Second question is a very simple one. This question is a simple one. Just read it and come to the answer. Perfect. This is a very simple one, right? 30-year-old, bloody stools, weight loss, anemia. Patient's past medical history is unremarkable. Did not take any medications. Fine. Father died of colon cancer at 40 years. I'm worried now. Younger sister suffered from endometrial carcinoma. Okay. Examination showed a right-sided abdomen tenderness and colonoscopy showed a right-sided ulcerative mass. No polyps are noted. Why is this very important? If I have polyps, multiple polyps, so what could be the first possible diagnosis? If you have multiple polyps, what could be the first possible diagnosis? FAP, right? So if you remember the diagnosis of Lynch syndrome as criteria, you must have heard about Amsterdam criteria. One of the important thing to diagnose Lynch syndrome is I should disprove it is not FAP. That's the first thing, right? I have to rule out FAP. Only when I rule out FAP, I can diagnose Lynch syndrome. So when I say no polyps noted in colonoscopy, it cannot be FAP. FAP will have 100% polyps. So this is not the answer. It's endometrium colon cancer. BRCA is not related with colon cancer. Might be related with endometrium, but not with colon cancer, right? MEN syndrome, there's no endocrine organs involved here. VHL will be related to your cerebellar tumors, your pheochromocytomas and your renal cell carcinomas, right? So the only thing required here is MSH2. MSH2 is a protein involved in my methyl mismatch repair. Fine. So methyl mismatch repair problem causes your Lynch syndrome. Fine. Okay. Perfect. Okay. Perfect. That's the answer for this question. Okay. Any doubts in whatever we discussed today? We shall keep discussing few of these. I want how many of you are aiming for USMLE, because that will help me to justify that I have to take a little bit of more classes for MLE, and that will help us to create content for MLE based, right? We are working on it. If we have your response, it will help us. Rajat, P53, sure Sunny, I'll do it. P53, when I have P53, first thing I should have a sarcoma. I'll write that. There are few things which will help me to think of P53. Sarcoma, sorry, just a second. CNS tumors, before it goes away, yeah. Sarcoma, CNS lesions, breast, leukemia. Two or more than two in this sequence, in the person or in the family, think of leaf Romney. Okay, these are the general tumors which can happen in leaf Romney. Okay, fine. Leukemia is more vital. If it is there, it will help me more towards the diagnosis. Hopefully it is fine. Okay, so thank you for your time. See you soon. I think I have one more class on your MLE this month. Hopefully we'll be discussing few more questions there. Fine. See you till then. Bye bye. Thank you. Bye.